All right, now it's time to discuss immunodeficiencies. And these are very high yield for step one. So, because of that fact, we want to get your mind into test mode. We're going to do that by playing a game, okay? And here's how it's going to work. I will display some symptoms, and they will be in blue font. You will then try to deduce and come up with a diagnosis for what symptoms I'm describing. And I'll give you a hint. The diagnosis is a type of immunodeficiency. All right? Then after that, we'll go over the mechanisms of that deficiency and some other extra boards fodder for your enjoyment. All right? You ready? That's too bad. We're going anyway. Here we go. All right, first case. We have a 6-month-old infant with recurrent bacterial infections. When we do imaging studies, we see no lymph nodes present. It's very interesting. On all laboratory studies, we see a normal pro-B cell count, but more mature B cells and all other cells are not present. What is the diagnosis? It's Bruton's A-gamma-globulinemia. Now this is X-linked, so who's going to inherit this? Well, males. Little poor males will inherit this. And remember the letter B, because it's Bruton's, it affects B cells, and the gene is BTK. Now, TK stands for tyrosine kinase, because that is what is defective and what prevents B cells from maturing into fully functioning plasma cells that can release antibodies. And without antibodies, you have no opsonization. Recall that opsonization assisted with macrophages latching onto bacteria and phagocytosing them. So without that capability, you will have massive invasion of bacteria and recurrent bacterial infections, as we just noted there. Next case. So this boy just received a blood donation, and right after that, he goes into anaphylactic shock, as we see here. He's had a history, his mother tells you, of recurrent mucosal infections, so like gastroenteritis and sinusitis. What do you think the diagnosis is here? This is selective immunoglobulin deficiency, and the most common type of that is IgA. So, without IgA, and you're given a blood transfusion that contains IgA, you will have a type 1 hypersensitivity response to that foreign IgA, and as described previously, you'll go into anaphylactic shock. Third case. This poor woman has a flare-up of an erythematous rash over her nose and cheeks. What autoimmune disease do you think she has? And let's say that this occurred after she went outside for a while. She probably has systemic lupus erythematosus, also known as just lupus. Then, let's say she develops later in life a lymphoma. Further lab studies show that she has a decreased plasma cell count and immunoglobulin count. What does she have? Common variable immunodeficiency is the answer. And this is unique in that it is an immunodeficiency that takes place later in life. So that's what you want to remember for this one. Now, this condition has numerous causes, all of which converge on the common feature of defective B cell maturation. This results in a normal number of B cells, but a decrease in the mass of plasma cells and, consequently, immunoglobulins. Patients with CVID are at increased risk of autoimmune disease. You must remember that. And lymphoma, because all of their immune cells are all disrupted without the normal cytokines released by normal immune cell populations. So remember that. All right. The next case involves a female patient who has had multiple spasmic contractions particularly when she gets her blood pressure checked. The wrist of that arm that is getting the blood pressure checked with a cuff on it goes into a spasmic contraction. First of all, what metabolic abnormality do you think she has? So the answer is hypocalcemia, okay? And why she gets these spasmic contractions is because with a lowered amount of calcium that she has in her bloodstream, there is relatively lowered amount of positive charge on the outside of cells in the extracellular environment. So the inside of cells is relatively more positive, which brings it closer to action potential and therefore muscle contraction, hence the spasmic contractions. So other abnormalities include she has some heart problems or cardiac abnormalities. She has an abnormal face appearance. She has an absent thymus. That's a big clue to this disease. She has a cleft palate, hypocalcemia, as we mentioned, and a mutation in her chromosome 22. So catch 22, what is her disease? She has DeGeorge syndrome or thymic aplasia. Now recall that the thymus is the place where what types of cells develop? T cells, okay? So she is lacking in T cells. And the thymus, if you recall from embryology, is derived from the third and fourth branchial pouches. And children with this condition experience recurrent viral and fungal infections because they have no T cells. Next case, this patient presents with disseminated tuberculosis, miliary TB, throughout their body. You see on CT scan and after testing the interferon gamma gold test. So, what deficiency might you look for then? Interleukin 12 receptor deficiency. The interleukin 12 is responsible for inducing T cells, if you recall, to differentiate into Th type 1 cells. A deficiency in the receptor, the interleukin 12 receptor, thus diminishes the Th1 response and can lead to disseminated mycobacterial infections as we see here. All right, the next disease can be summarized by the mnemonic FADED, or the acronym FADED. The F is for Frankenstein face. Sorry, but that's what they look like. A is for abscesses. They get recurrent Staphylococcus aureus abscesses. The T for teeth. They retain their primary teeth, so no tooth fairy coming for them. The E for an increase in IgE level in their serum. And finally, the D for dermatitis. They have chronic candidal infections on their skin and eczematous dermatitis. What syndrome am I talking about? This is autosomal dominant hyper IgE syndrome, also known as Job syndrome. And what is it due to? It's caused by a deficiency in the cytokine interferon gamma. Do you recall what interferon gamma is responsible for? Well, one thing is it induces chemotaxis of neutrophils and helps them leave the bloodstream and enter tissue to fight pathogens. So if you don't have that, then you're going to have recurrent bacterial infections and recurrent abscesses, as we just mentioned before. Another thing that interferon gamma does is stimulates Th1 cells to differentiate and mature. Recall that the precursor Th1 cells developing in the thymus need interferon gamma to fully differentiate. So when Th1 is low, Th2 is relatively higher. And that's why we see an increase in IgE, because recall Th2 cells are responsible for releasing, do you remember what cytokines? Interleukin 4 and 5 that class switch B cells and tell them to start making IgE. All right, the next case involves a poor little child who has a mouth full of cottage cheese. Not literally, but it looks like cottage cheese. What do you think this diagnosis is? This is oral thrush, and it's due to Candida. albicans, fungal pathogen. Let's say he has candidiasis all over his body. What do you think the diagnosis is? This is chronic mucocutaneous candidiasis. You see disseminated Candida infections, and what's it due to? It's a T cell dysfunction. As we just talked about, T cells are important in combating fungal and mycobacterial infections. So specifically with this condition, they have a difficulty with battling fungi on the skin, and specifically Candida albicans. That's the most common. All right, the next deficiency is the bubble boy deficiency. Now, why are they in a bubble? Because otherwise, they'll be exposed to viruses, bacteria, fungi, and protozoa that will all go to town on these poor kids, unless they're protected. Well, why is this? Well, let's say you do a CT scan on them. You'll see no thymus. Now, what does that imply? No T cells, okay? And you see no lymph nodes evident. What does that mean? No B cells. So both T and B cells are missing. What is this condition? This is severe combined immunodeficiency, also known as SCID. Now, what's it due to? You can remember the reasons using the acronym RAM, R-A-M. The first one, which is the most common reason for this condition, is a receptor defect of interleukin-2 receptors. What will this lead to? You know, a decrease in T cell activation, because interleukin-2 is the T cell stimulator, as you recall. This is the most common, as I just said, and it's X-linked. What does that mean? Boys, right? That's why you remember bubble boys. Poor kids. The next reasons are a little less common. The second one, the A, stands for adenosine deaminase. And without this enzyme, there will be a buildup because there will be a lack of degradation of ATP and deoxy ATP. And both of these products stimulate negative feedback on ribonucleotide reductase, which you recall from biochemistry, probably. Do you recall that? I didn't think so. But there will be negative feedback on this enzyme and a decreased synthesis of DNA, and thus a decreased population of lymphocytes, and in turn, SCID. The final reason is MHC2 receptor defect. And as you know, this is important in communication of all antigen-presenting cells. So that's a big-time problem. You're going to get SCID if you have that, because you will not have the co-stimulation between immune cell populations. All right, let's keep moving and now discuss the A deficiency. The A stands for ataxia, right? They're very wobbly. They have a difficult time keeping their balance. Angiomas, as we see here in the sclera. Another name for angiomas here are telangiectasias. That's important. IgA deficiency is the final characteristic. What is this condition? Well, the reason I said telangiectasias are important because that is part of the name of this diagnosis. The first part is the other symptoms. So just know these two things and you know this disease, and it is ataxia telangiectasia. Wow. Somebody was very creative naming that one. What is this due to? Well, it's a defect in the ATM DNA repair gene. Now, it's not to say they have a difficult time getting cash out of ATMs. No, they have a problem fixing broken DNA. They also have a problem making too many blood vessels and keeping their balance. Next case. We have a 6-month-old infant with severe purulent infections. He has a massive increase in IgM, but a decrease in every other type of immunoglobulin. What do you think this is? This is hyper IgM syndrome. Again, very creative with the naming. So what is it due to? Well, if they have a massive increase in IgM but nothing else, there must be a problem with class switching, right, of B cells. And you recall that the CD responsible for class switching is CD40 ligand. So, without this class switching, there will be no IgG, which you recall from earlier too. That's an important opsin and allows macrophages to latch on to pathogens and phagocytose them. So if you can't do this, you're going to have pathogens take over your body, hence the recurrent purulent infections. So we have another poor kid who has thrombocytopenia, so low platelet count. He has recurrent infections and eczema, as we see here. Don't mind the face. This is not Job syndrome. Just pay attention to the eczematous skin, okay? When you look at his blood, he has a low IgM count. What do you think this diagnosis is? This is Wiskott-Aldrich syndrome. And this is due to a progressive deletion of B and T cell counts. That's why we get the recurrent infections, because of the B cells, and why we get the eczema because of the T cells responsible for eliminating Candida albicans. All right, so a way to remember this is TIE. All right, this is the classic triad of Wiskott-Aldrich, TIE. And how I remember it is Whiskers the cat with an X-shaped bow tie drank all the milk because he lapped up all of the IgM for milk. All right, and bow tie, because that's the triad, and Whiskers the cat, because it's Wiskott-Aldrich syndrome. Also X-shaped, I say that because it's X-linked as the mode of inheritance. Moving on. All right, this one's easy. So we have a kid with recurrent bacterial infections. However, all of these infections are just red and tender, but no pus, no purulent discharge is noted. So neutrophils are not going to the sites of infection. And here's the dead giveaway. There's no natural separation of the umbilical cord. Now, that must involve a lot of pulling and tugging on mom's part and a lot of pain on this poor kid's part. Ouch. What is this diagnosis, though? And the key really is this no umbilical cord separation. When you see this on USMLE, you are thinking leukocyte adhesion deficiency type 1. It's due to a problem with LFA integrin protein, or CD18. Now, what's the significance of this? Well, leukocyte adhesion implies that leukocytes, or white blood cells, are adhering to something. And that something is the CD18, or this LFA integrin protein. So they need to attach to something to stick to the sides of blood vessels and exit into tissue to go fight infections. Otherwise, you'll have recurrent bacterial infections. And to help the umbilical cord separate by releasing all of the reactive oxygen species and detaching this little guy. Second to last deficiency is a poor kid with infections, albinism, so he's pale white, neuropathy, can't feel his fingers, has motor weakness, and coagulopathy, frequent nosebleeds. All right, what is this condition? This is Shidiak-Higashi syndrome. And how are you going to remember this? Well, all you have to know is that it involves a problem with microtubules, all right? And specifically, the LIST gene is affected. What do microtubules do? Well, first of all, they assist with motility. So macrophages, from traveling around, they need pseudopods. And pseudopods require microtubules to bend and act as little arms, I guess, for these pseudopod structures on macrophages. So if they can't get to a site of infection, you'll have recurrent infections. Additionally, microtubules assist with deposition of granules into cells. So any cell that depends on and uses granules will be affected. And that includes melanocytes. If you think of them transferring melanosomes to keratinocytes, that involves microtubules. So they will be pale without the melanosomes because they have no pigment in their skin. Neuropathy, okay? Transferring nutrients down an axon, down a very long axon, requires microtubules to assist with that transfer. Well, without nutrients, the axons will start to get weak, hence the neuropathy. And finally, platelets have an abundant amount of granules within them, but they won't. The alpha and delta granules, von Willebrand's factor, and fibrinogen, they won't have that because microtubules won't be able to deliver that to them. Hence the coagulopathy and the frequent nosebleeds. All right, last one. And actually, it's an easy one because you've seen it before. So, a poor little boy has recurrent infections, or actually granulomas. That's a little bit of a hint here. And it's caused by catalase positive, like staph and aspergillus. Ringing any bells yet? This is chronic granulomatous disease, as we discussed earlier. What's the enzyme it's due to? It's NADPH oxidase. And the mode of inheritance is X-linked recessive, hence little boys. So just to refresh your memory, NADPH oxidase converts plain old oxygen into, do you recall? Superoxide free radical. And this charged particle then is turned into hydrogen peroxide. What's the enzyme responsible for that? That's a tough question. Superoxide dismutase. And finally, peroxide can be converted into the most powerful, most potent volatile free radical you've ever seen. What is that? It's over-the-counter bleach. Hypochlorite. All right, that is very toxic to pathogens. What's the enzyme responsible for that? Real quick, myeloperoxidase. So, recall that with this condition, they're missing the first step, right? No NADPH oxidase. But most bacteria and most organisms still release a small amount of endogenous hydrogen peroxide that these affected individuals can convert into bleach, which is, again, a very potent and powerful free radical and still kill pathogens. However, catalase-positive organisms, like staph and aspergillus, can neutralize all available peroxide into water. So these kids have nothing to take out those organisms. And instead here's a little bacteria, instead they just wall them off and form little granulomas like we see here. Hence the name chronic granulomatous disease.